Welcome to Same Surgeon, Different Light. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast. My name is Sherry Erkman, and together with Sara Pereira, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We'll learn about backstories, career challenges, and what makes each cardiothoracic surgeon unique and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
Welcome to Same Surgeon, Different Light. I am Dr. Sara Pereira, and today I'm happy to be joined by Dr. Brittany Zwischenberger, Associate Professor of Surgery at Duke University School of Medicine. Dr. Zwischenberger is an accomplished cardiac surgeon and seasoned clinician who has received numerous research grants and published many peer-reviewed manuscripts. Her contributions to the specialty have significantly advanced the understanding and treatment of coronary artery disease, and she is widely regarded for her expertise in minimally invasive cardiac surgical techniques and research. Today, Dr. Zwischenberger will share how her mentor, her father, a cardiothoracic surgeon, shaped her path into medicine, despite briefly considering a major in Italian studies. She will also discuss the evolution of surgical culture during her training and how her experiences as a medical student and resident led her to becoming Duke's first female associate professor of cardiac surgery. Dr. Zwischenberger, I've been fortunate to know you for almost 10 years now and really look up to you. You were a cardiac surgery fellow at Duke University when we met, and you were just looking for your first job. And I know you were raised in a medical surgical family and how tough you were based on your experiences in Kentucky and at Duke University. So I'm really welcome to our podcast, and I wanted to start with your childhood background. Your father is a well-known cardiothoracic surgeon, which of course makes it difficult in itself to want to pursue cardiac surgery. And I'm wondering how difficult it was growing up with a surgeon as a father. I've tried everything to give my daughters a positive view of women in surgery, and particularly cardiac surgery, through the years, but they have not decided to pursue medicine as of yet. So how did you develop your own interest in surgery, and what inspired you specifically to go into cardiac surgery?
Well, thank you so much for the invitation. And this is such an honor to have a voice among such a broad base of aspiring and current cardiothoracic surgeons. So yeah, my dad, of course, my primary mentor my entire life, and he always wanted me to pursue medicine. And he always, as I got further along, he wanted me to pursue surgery. He held medicine in such a high regard, but he always wanted us to see him as a dad. So even though he got home late at night, on the weekends, we would always do stuff. He always showed up to soccer games and reviewed my homework and reviewed my manuscripts, and always took the opportunity to destroy any of my papers because it was too fluffy. And I really resisted it at every turn. But he helped me get there by teaching me work ethic and really most importantly, not to burn bridges. But I had to land here on my own. When I was in high school, he had me participating in bench labs with surgeon scientists, and physician scientists who really appreciated that medicine was serious business, and that being a scientist took the field to the next level. And that was just so neat to meet with those mentors early on. In college, I wanted to do biological anthropology, which was actually my major. So I got a bachelor's of science, which of course he called the soft science. And so it's just every step along the way, he said, well, don't, before you become an Italian studies major, why don't you take some science classes first? So, I remember the day that I said that I wanted to be an Italian studies major, and he was like, not even Italians speak Italian. So, so I had to make some modifications. And then in med school, it was a pretty malignant place for general surgery. And I had very trite reasons not to do surgery, like I don't want to wear scrubs all day, and pursued dermatology. And then really what changed everything was when he said, you need to see the surgical side of dermatology, and asked me to do rotational plastic surgery. And that was the moment where it was like clouds parting, sun coming through in the operating room, when I thought, this is where I want to be for the rest of my life. And then I ended up doing general surgery and liked every rotation, but it wasn't until, and the whole time, once I started to do surgery, he was like, okay, you should do CT, right? Obviously, that's the only thing to do. But it wasn't until I was a fourth year general surgery resident doing the overnight CTIC rotation that I really appreciated the hemodynamics. And I'd always been drawn to the sick patients, but appreciating the hemodynamics. And that's where I was shining technically, because when I was on trauma, they were like, well, you can't make decisions, and you're too focused on the details. But then on CT, it became a strength, right? Because I was prepared for cases and focused on my technique, and then everything lined up afterwards.
Do you remember telling your father that you were applying to cardiac surgery? And if so, what did he say?
He was excited. I mean, he once I told, of course, it's my dad. So when I told him that I was going to do CT, he was like, yeah, I know. So it was already obvious to him that was what was going to happen. Because he had seen me as an intern and early and junior resident, again, attracted to the sick patients. And he was like, that's where you need to be.
What about your siblings? Do you have siblings, and did they go into medical careers?
So I'm the oldest of four, and then my next sibling, my sister Andrea, is in hospital in medicine, but on the dark side. She's a hospital administrator. So we all have good chats at the dinner table. And then my next sister got into the car industry, and she's a car girl, as she calls herself. And my dad actually restores old cars, so I think that was another influence. My dad on Christina. And then my brother Charlie is in the seed business in Kentucky and took over the family business.
Oh, that's great. So you went on to complete your medical school at UT Southwestern, and then residency at University of Kentucky, as you said, and landed at the prestigious Duke University for fellowship. Can you talk a little bit about how you've seen the evolution of surgical culture through your training, and how it's evolved now that you're faculty at Duke University?
Yeah, I think, starting out at UT Southwestern, that was a really tough place. And I don't think that that's new to anyone, that it's got a very tough surgical culture. And I really thought when I was a medical student there that a light inside of me would go out. And so that's what was so life-changing about going to Kentucky on the surgical side, because they were very nice people. And really the paradigm was making you feel so responsible for the patients that you would feel like you're disappointing the patients and you're attending if you did something wrong or if you were underprepared. So that was a really neat place to train. And half of their surgical residents become a general surgeon the next day. So they're very focused on training surgeons to be there for the health of Kentucky, which means that they expected you to be polished by the end. But that was really formative for me as this female surgeon, because I had to figure out the dynamics. And I tell people all the time, what they say about women in surgery, it's all true, And so, especially in Kentucky, the nurses, had a really hard time with me, and I had a hard time with the nurses. So it took me 5 years to really soften my edges and figure out how to talk to the nurses. And I didn't figure it all out at the end. And so it was great for me to reset at Duke, where I was a little bit more evolved, not completely evolved, but certainly more evolved than when I started. And Duke is just really a magical place, because that even from the moment that I interviewed here, it was clear that they're about absolute excellence. And I have always used this analogy to think about Duke when I interviewed here, it was obvious that, this place was the train going really, really fast, and you could be on the train or you can be off the train. If you're off the train, go home. If you're not part of what everybody else is doing, there's no place for you here. And I've always been impressed with everybody I talk to is super smart, super top on their game. We might not agree, but you can at least have an intelligent conversation with them. And everybody wants what's best for the patient. And Duke cardiothoracic has its own group, anesthesiologists, and really everybody wants to go above and beyond. But even here, the culture has evolved in the past 10 years, especially for women.
Well, congratulations. We were recently at the International Coronary Congress in London. You told me that you were promoted to Associate Professor of Surgery at Duke, which is a great achievement. And I think that you were the first female cardiac surgeon at Duke with Dr. Betty Tong in thoracic surgery. Is that true? Are you the first Associate Professor of Surgery as a woman in cardiac at Duke?
Yes.
Congratulations.
Yes.
As you know, Brittany, we are facing a true shortage of women in academic cardiac surgery, and many of us have really tried to advocate for women within our various national organizations. And you're one of a very few early to mid-career academic role models for me and all residents and fellows in training. And so even with our positive progress and all of our recent attempts over the last 5 to 10 years, still we see only about 3 to 4% of women are choosing cardiac surgery, which is similar to interventional cardiology, surprisingly. And what I've seen is the transition of women into private practice after a few years in academics, which I knew that at one point you were considering. So what do you think that we can do to retain our strong women in our training programs in academic practice as well as cardiac surgery?
Well, the topic of culture and women surgeons, especially in cardiac surgery, is just such a big answer. And I think on the meta view, Women in Thoracic Surgery has organized us like never before. And even that organization has evolved so much and grown so much. And there really is a lot of push for mentorship for females. But I've seen that we've made such an effort to bring female mentors to female trainees. The pendulum has totally shifted, right? Because 10 years ago, or even greater than 10 years ago, when I was looking at CT, I was talking to thoracic surgeons, the female thoracic surgeons, to get a sense of whether I could even do it or not, right, as a woman. And they said yes, but we've done such a good job of providing forums and connections for women and women trainees that the pendulum has shifted. And now some of the current female trainees, they're like, what's all the fuss about? Like, what's the big deal? So it's interesting to see that shift, that we've done such a good job. And yet, as you described, the numbers really haven't changed. At Duke, I was pregnant. I was the first one to be pregnant as a female and pregnant as a trainee and as an attending. And it was neat to see how the culture changed over time. And when I was the trainee, I just tried to make it seem like I wasn't pregnant. And there was nobody ever said anything, at least to my face, which is all I really cared about. But I was able to be pregnant and nurse. And my bosses were all very supportive, and taking a break out of a big aortic case with Chad Hughes was kind of intimidating, but he was very kind about it. The PA came in for 20 minutes. But like I said, I think all of the rumors are true. And there's a great quote from Jimmy Iovine, who's a record executive. He says, "I always felt like I had to work harder than the guys to just do as well as them. And to do better, I had to just kill, and I think that is still true for the females a little bit. But shifting to mentorship and sponsorship, it's almost a loaded desire. It's a loaded description, because the ideal definition is somebody who's going to get you through every step of the road. And it's not truly attainable, right? You can't have one person do all of this for you. Especially I see like chiefs looking at jobs and they want a mentor, or when somebody's applying, they want a mentor. They want somebody who tells them how to act and tells them the next step and tells them how to write and teaches them the landscape and teaches them the technique and gives them cases, right? And sponsors to put you on the committees, and it's just impossible for one person to do that. And so I think what I've learned is that the answer to retention and academics, especially for women, is really to have it's like a stock portfolio of mentors and sponsors, right? So multiple mentors. As soon as I joined the faculty, I had cardiologists actually who helped me with research, right? And they were just such good methodologists, and they have the time to do the methods and to teach you the methods, right? I have a radiologist who's a mentor, who's a female and has had to navigate Duke for 15 years. And she was really good at helping me think about kind of the big picture of the cardiovascular political scene. But then as I started to advance and I got my feet on the ground and I was a faculty and I wanted to be a surgeon scientist, I was really fixated on keeping up with the guys in terms of my volume. And actually Joe Chickway was the one who helped me pivot a little bit, because I had shared all of my frustrations about like, oh, my volume's not having high enough, and I've got this research and this isn't enough and this isn't enough. And she's the one that was like, it doesn't really sound like you want to be the highest volume surgeon at Duke. And I was like, no, I can't. There's no way to be the highest volume surgeon and then do the research as well. And so after she gave me that perspective, I started to cool it off on the volumes, right? Because you go to the meetings, everyone's talking about the volumes, but if you have a greater goal, it's not just the volume. And then I had kind of a second emphasis on that perspective when I was thinking about leaving Duke, and I started interviewing, like you alluded to. And actually, it was Yoshi Kaneko who said, he listened to me when I was thinking about leaving, and he was like, but what do you want? I mean, it sounds like you want to do research. And I was like, yeah, I want to do research. And he was like, so why are you leaving Duke, right? And so it kind of took those people to put things in perspective for me, and stop fighting to be like everybody else, right? I had to just make my own narrative and make my own path, and that takes emotional intelligence and maturity to get to that point. So, but I think that the answer for keeping women in academic surgery is having this kind of stock portfolio of mentors, because one person just can't possibly be what we're all seeking.
Yeah, I think that's great advice. And certainly, we have various mentorship programs within STS and Women in Thoracic Surgery. And so to all listeners that are interested in expanding their portfolio, really, it is important to get external perspective. You alluded to pregnancy, and I know you're extremely proud of your children. I wanted to shift our discussion to a topic that certainly is more personal and very difficult, and I really appreciate you agreeing to talk about this. I think at our national meetings, we don't talk about the most painful parts of ourselves at times. And as you were growing into this very successful and highly respected female cardiac surgeon that you are, you were really not happy in your personal life and not thriving early in your career. I think once when I saw you at American Heart Association, you were just going through a really horrible divorce. Are you comfortable talking about this life transition and how you have really rediscovered yourself and your family as well as your kids?
Oh, absolutely. I mean, this is something that you can't survive without other people and without other stories. And it did change everything about me, because I had lost myself so much along the way of training, because you just are so focused on reading and studying and technique and showing up at the patient's bedside. I remember at one point I stopped listening to music, which is so important to me. I love music so much, and I'm always listening to it. And I hadn't listened to it for months. And I literally, like, one day during training was like, what happened, right? Like, and that's just one example of a way that I had become such a different person, and had lost so much of my own personality. But yeah, I made a life-changing decision when I was an intern, and I decided to get married, and it was hard for me to see as a general surgery intern in Lexington, Kentucky, how I was going to evolve, and certainly the trajectory of my life. And the toxicity that evolved in my marriage was insidious. And we kept thinking that it would get better at the next turn, at the next milestone, like maybe when I finished CT fellowship, like everything would get better. And when I became faculty and started making more money, or maybe when we had the third kid, things would get better. Or maybe when we bought the big house, that things would be better, but it never did. And we grew apart. And it ended up being a pretty high conflict divorce, and certainly the hardest thing that I've ever been through. But now I have such a kinder perspective, and I'm able to articulate the experience in a more productive light. And that it's actually captured very well by this quote by Justin Sua, who's do you know him?
No, I don't.
He's a coach for professional baseball players, and he does a lot of podcasts and stuff. But he says there's some people that come into your life that are like boosters for a rocket ship, but the boosters fall off when the rocket reaches a certain altitude. They're not equipped to handle the altitudes that I'm going to. So I can't be afraid when they fall off. They're not bad people. They're just not ready. And now that I've gone, it's so clear to me that that's exactly what I went through. Right. And everything changed. So once I started to reset, when I started this divorce, I realized how much my personal life had affected the person that I was at work. And there's always these microaggressions and these macroaggressions that are developing, especially for females, but I didn't realize how they had festered. And so I worked with a coach. I invited him into the OR. So this was in the middle of my high conflict divorce. So it was very intense, that like there was a big bomb in my personal life and a bomb at work. But once you fall down, you get back up again. And so I invited him to the OR, and I introduced him. I said, hey, this is a coach that I've been working with, and I trust him completely. And he's here because I want to become a better leader. And he sat down and talked to the nurses and talked to the residents and talked to the anesthesiologist. And by, I think, exposing myself, making myself so vulnerable, people saw a softer side for sure, that they could reconnect with. And there were things that I changed. I kind of reduced the intensity. Your first few years, everything is important. And by then I was ready to see that, there were certain things that weren't so important. And so just to cool off the temperature in the room, I started speaking much slower, right? Because my nature is to like a EDM song, right? Like I'm like vibrating at max speed, but I slowed down, and I was way more conscientious about people's names. So if I needed something in the room, I would take a look, see which nurse was available. I would call that nurse specifically. Hey, so-and-so, can you please change the bovie, the top bovie? And then I would say it slowly and wait for them to respond. And they do want to help, right? Like they do want to come help, and they do want to do what's best for the patient. And I think that doing this coach helped me appreciate how much they were there for me, right? I didn't have to get so irritated. And if I rattle off 3 things for them to do at once, it's hard for them to prioritize. I also started doing meditations every day, and there's this fantastic podcast called The Knowledge Project that interviews leaders, and it's with Shane Parrish. And many of the quotes that I used in my daily life, I got from The Knowledge Project. And I have this fantastic story from my boss, Carmelo Milano. We were close to each other in the office, and I was having a really hard time with the female anesthesiologist. And it was getting so bad, like I felt like they didn't like me, and there was tension, and I was avoiding going to the female locker room. And I told him this story, and Dr. Milano is, he's absolutely the consummate surgeon, and he's at the top of our game, and top of his game, and he's trained many people. He has so much perspective, and he has a very calm demeanor. And he said, you know what, Brittany? There's this book that I read that I think you need to read. Okay, what is it? I'm like vibrating. He's like, it's called The Subtle Art of Not Giving a Fuck by Mark Manson. And I read it. I listened to it, and it was amazing. Right. It was just absolutely amazing. And it had these little quips, and this guy just sat down and wrote this book. And then certainly friends and family, like I couldn't have gotten through the divorce without friends and family. And um my ex-husband worked from home, and so he had this infinite time, right? Which is the exact opposite of what we have. And so he was always able to beat me if you can give me the the freedom to call this slightly a competition as parents, and we were competing as parents and competing during the divorce, but he had infinite time. And so I think that that gave him a lot of flexibility with how he was parenting. And that was something else that I had to do, was rebuild my confidence as a mom, because I really was acting as um, this full-time cardiac surgeon, and my husband was the stay-at-home quote parent, right? And so he was managing everything. So I had to, during the divorce, going 50-50 custody, I had to rebuild my confidence as a mom, start reading all the emails from the school, organize my day, get a nanny. And during the process, one of my aunts came in town, and she had breast cancer when she had a 4-year-old, and she was a single mom working alone. And she watched me catering to my kids, like, hand over foot, 16 meals at dinner. And she was like, what the F is going on here? She was like, you can't let them make all the decisions, right? Like, you have to create extreme structure to make it work as a cardiac surgeon. And she was totally right. So I kind of blew up the way that I didn't use my ex-husband's template of just maximal flexibility, whatever the kids wanted. And I was like, okay, we're going to run the household. I'm going to be a mom the way that I structure everything else, right? Like, there are rules, there are limits, there are times, there's one meal. And then that also helped me, just in terms of anybody listening who's wondering, how in the hell do you do this as a cardiac surgeon? You have to have extreme structure. So it's a very long answer.
Wow, you wrapped up so much great advice in that answer, from how you learned and evolved in the OR. And I know the music was a huge thing. For a while, you told me you were wearing earplugs in the OR to listen to your hip hop and dance music so that you
The
could.
bone conduction, so I could still hear perfusion.
Yeah, I mean, that's really huge, to going through a long-term divorce, coaching, relearning your way as a mother. That's really a lot. And I would think that this was a 5+ year period of your career. And divorce is really prevalent amongst physicians and surgeons. Is there anything also that you think would have really helped you during those years, that we could help some of our peers going through similar situations who may not have as much support and resilience as you have really shown?
Yeah. Well, I think there's so many women and men out there who have gone through similar experience, and finding somebody else. I mean, I had a whole phone list, a whole catalog of people that I could call at any time. Like, let's say, I mean, my family was amazing and fantastic in all the ways. Childhood friends were fantastic, extended family, and people who had been divorced before were just amazing. Just to say, maybe they were at the same phase as me, and so we were able to talk about how things were happening at the same time, or people who've already been through it. And sometimes if I just, actually, one of my residents, while we're operating, mentioned that her parents were divorced, and I totally came zoned in on it in the middle of a case, and I was asking her all these questions. At this time, she didn't know that I was getting a divorce, and I was like, well, how did that affect you? And I think that the most influential advice that I received from other people was from kids of divorce, because I was so terrified of losing my kids and doing the wrong thing for my kids. And actually that kept me in the marriage for quite some time before I decided that I just couldn't go on, right? I was afraid to lose my kids. And you will not lose your kids, right? It's going to go 50-50, as long as you're a functional human. And I think that hearing my colleagues, my contemporaries from divorced parents, the strongest message I heard was that they were so happy when their parents got divorced, because they said the only thing that I gained from being the child of a toxic marriage was emotional intelligence, because you had to read the room when you walked in to see like where were the parents, right? Were they fighting or not? So the children, I think the all of the data shows that the kids that are loved by both parents, that feel safe at both parents, that they turn out fine. So I think that you can't lose your kids. You can go for 50-50 coverage. Having said that, it required so much help from my partners, just to blow up my schedule. And actually my cardiac surgery partners were some of the first people I told, like before my family, because I had to go to them, because the first thing the lawyer said is like, your schedule is not going to work. This is a problem. She's like, you got to fix your schedule. And so I went to my partners and I was like, hey, I have to change my week and make it super rigid and super structured, because on Mondays and Tuesdays, I have to be showing up for the kids, right? So I have to take them to school and I have to pick them up. So it's basically kind of an 8 to 5. And with the nanny, sometimes I'll wiggle on each end. But they immediately said yes, no problem. And so we changed it to where my call day is always a day without the kids. And if there's a problem with my patient on the days that I do have my kids at the house, my partner said, yeah, we'll cover for you. And so if certainly I have those Monday, Tuesdays, so there's the weekend to get through a post-op patient. So the last day, presumably I operate on somebody is around like worst case Friday. And by Monday, when I have the kids, there's a couple of days for the patient to get through that kind of acute take back phase, right? So I think logistically sitting down with your partners, like all of them, and saying like, okay, this is happening, right? I'm getting a divorce. I have to have 50-50 custody of my kids. And this is what I need. And being totally frank and open about it was super helpful, because certainly I have a group of partners who are never going to reject a case, right? So they are like case hungry. So that is very helpful. But being transparent with them, I think that cardiac surgeons do very well with information. And if I just started, not answering my phone and not showing up and calling them for help without them understanding the origin, it would have been much more difficult. What I would tell people is not to be afraid, but really to harness that fear that you have and use that to push you forward, because there is a better light, right? There is a better life. And now I just have such an amazingly rich life. And I just love the interactions I have with my kids. I'm, such a better mom. And I found a partner who is going to go with me on that rocket ship, right? To the next level, right? And it's just such a beautiful view from up here. I'm happy that he's going along with me.
Brittany, it's been really, really amazing to see you at your low a few years ago, and now just really thriving so much with your current partner. And I really thank you for sharing that with our listeners, as I personally think it's so very important. I wanted to ask you about the robot. I know you have this zest for robotic coronary surgery, and you're incredibly awesome with the clinical trials that you're doing and all the work you're doing. And as you know, our specialty has changed incredibly over the last 8 to 10 years. And now we have integrated residency programs that are hugely successful. We have innovation and structural heart and robotics. You're really leading the minimally invasive and robotics approach to coronary revascularization and multi-arterial grafting. I've quoted your papers in several recent presentations. And you're the primary investigator for Roma and Recharge. So if you were to look forward 10, 20 years now, well, you'll still be in practice. Where do you see our specialty going?
Well, robot is tricky. So I want to start with cardio. Let me, one correction is that certainly Mario Gaudino is the principal investigator, but I am a site PI. Or I'm very proud of that. So I have to always give him his recognition. But so robot is tricky. So I would start with really cardiac specialization, which does have the advantage of perfecting a craft. But I couldn't have started to work on this perfection of a craft without a holistic competency in cardiothoracic surgery. And a really good example is adding on dissection call in my practice. So when I started, we had 4 guys who were doing aortic, And it was a pretty tight group. It was a tight call system, and the 4 of them took all of the aortic call. And so I did a ton of CABG and some valves. So my first couple of years, the majority of my cases was isolated CABG, and I loved it, and I was getting good at it. And I was invited to, after the guidelines came out, I was invited to talk about it. But I realized that, kind of behind the scenes, the muckety muck and the talking it up before and after the panels with my other cardiac surgery colleagues is I really wasn't able to talk about the whole spectrum of cardiac surgery. And that was because I lacked, some aortic experience. So these guys and Dr. Lawton would talk about doing multi-arterial grafting, and then afterwards they'd be talking about circ arrest, and I was like, well, I don't really have that skill set right now. So I approached Chad Hughes and asked if I could add dissection call to my purview, and so I've been taking that for several years, and that's absolutely helped me run the gamut of being a adult cardiac surgeon. So I think that for training, we want to train surgeons to evolve and train them to integrate new techniques wherever the evidence is taking us, right? Because actually, let me say that differently. We want to train the residents to integrate new techniques, even when they're not evidence-based, right? Because new technology, new techniques are never evidence-based, but you can still see empirically the benefit of it. And multi-arterial grafting is a great example because you can see that they have great patency, and for certain patients, the role is clear, right, to us. But we still haven't been able to show it absolutely positively with a randomized controlled trial yet that multi-arterial grafting has a role. So teaching the residents that this is a technique and it's appropriate for some patients. It's not appropriate for the ones who you don't care about, right? Super long-term patency. So we want to teach them the ability to evolve and really the value of evolution. So I make micro changes in all of my cases. So isolated CABG is a good example. It's such a hard operation, and the coronaries are always different and difficult, and the graft is never perfect, and you are always trying to improve your bag of tricks. And so maybe it's the workflow, maybe it's the way that I put that stitch, maybe it's the way that I create that graft. I'm making these micro changes, and then I won't make a change for a couple cases and see how that plays out. And so I think a take-home message is that, if I feel that if I'm doing the same thing now that I was doing when I was in training, I mean, just take me out back and shoot me. What's the value of that? So I think that is a fundamental lesson for our trainees, not necessarily that we have to take them aside and do a coronary subspecialization for a few months. So again, multi-arterial grafting is a good example of figuring out how to evolve. And so we teach the resident multi-arterial grafting, but then they have to be aware of all the external factors that play into whether they can do that in practice, right? So depending on where they go, let's say that there is no multi-arterial grafting, say they aren't doing a radial artery harvest. So they need to have the ability to look at the big meta view and see what are the obstacles, what are the extrinsic factors. Is it leadership? Is that we don't have any PAs that know how to do an open harvest, that we don't have any PAs to do an endoscopic harvest? Well, how do you do that? How do you bring that infrastructure and those resources to the operating room? What's the readiness, right? I mean, what's the readiness of the nurses to do something different? So, but and then now to apply that to robot takes a lot of infrastructure, and it's hard to train, and it's hard to train robot mitral. It's hard to train robot midcap or at least robot mammary artery harvest, because if you mess up that conduit, then the whole operation is over. And so I encourage the residents, like, look, if you're interested in robot, come in and watch the workflow for several cases. But really, if you want to do robot, then that's a conversation to have when you're doing your initial contract, right? Or maybe the first job just says no, and then you do it with your next contract. But you have to ask for the resources. What is the lay of the land? Are other subspecialties doing, or are other specialties doing robot? Do they have credentialing criteria that you can reach? Do you have the time? Do you have the robot time? I mean, thoracic is a good example because they have to get a room for the whole day. And I know that many of them are competing with the general surgery operating room. So at Duke, we have only recently managed to get a robot for cardiothoracic. And so we share, cardiac shares it with thoracic. But that took years, right? And so to finish your training and to go on to do a robot fellowship for a year and then go to a job that doesn't have anything in place, well, then you're going to get behind on your skill set. So I think I've encouraged them to understand the lay of the land, understand the resources necessary, couple that with the hospital that they're going to and the contract that they're designing. And then once you get there and get your feet on the ground and become a heart surgeon, then you can go to, the STS robot courses and really start to pick up the skill set. And then the robot senior surgeons in cardiac surgery are just so phenomenally supportive for mitral and coronary artery bypass. So I've had multiple conversations with senior people who just want to help me get better. And so I can call them anytime and ask them questions, or they'd be happy to come watch us do a case, or I can come watch them do a case. So there's really a nice network of senior mentorship that's available right now. But I think get your feet on the ground, narrow your focus so you can increase your impact. Over time, my definition of the triple threat has changed. When I was a student and a resident, the triple threat was surgeon, scientist, educator. And along the way, I had to change that for myself because that wasn't sustainable. My triple threat is that I want to be an excellent clinical surgeon. I want to be a productive surgeon scientist. And then my third thing is to be a wonderful mom. And education is very important to me. And I set up a paradigm of intentional teaching, but I had to let the associate program director go.
I think that's really great advice. And it's been such a joy to see you thrive. And I really appreciate all of your sincere and genuine answers to really tough questions about your life and career today, Brittany. I think speaking on behalf of all of us as women in this field, we've all had our own challenges, opportunities, and successes. And I think you exemplify all of that. So really, thank you for joining us on our Same Surgeon, Different Light broadcast today. I also wanted to thank the Society of Thoracic Surgeons for sponsoring the podcast series. Do you have any last great advice for our listeners today about what your future will bring?
I think keeping in mind that we've gone through multiple phases of my life, and I think I've learned that every next level of life will demand a different version of me, right? And you can't be afraid of that. Don't waste time doubting that transition, right? It's natural and it's necessary, especially to evolve as a cardiac surgeon, right? You start off as an intern and then you become a leader in the room managing an arrested heart, right? Like we have to evolve. And I think for my own future, I want to be a voice in CT surgery and not an echo. And I carry that with me when I'm making decisions about how I manage patients and our future directions for research. Thank you so much to the STS. I'm so honored to have this platform to talk about my own story. And Sarah, thank you for your fantastic questions.
No, thank you.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT Surgery. And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.